We are live now, ma'am.
Yes, Chitrakala.
Good evening, sirs and madams. Welcome to this session. AMOGS Medical Disorder and Pregnancy Committee in association with TNFOG Infertility Committee, Maharashtra and Tamilnadu. So the first session is Kuttuvilakku lighting, lamp lighting. தமிழ் தாய் வாழ்த்து. With the kind permission of the organizers, Dr. Rajendra Singh Pardeshi sir, Sujata madam, I invite our TNFOG president, Dr. Professor Revathi ma'am. She is the founder's vice president, Foxy South Zone 2016 and president.
Okay, Radhika, President TNFOG is good enough. Okay.
Okay.
Thank you.
Thank you.
Good evening, dear friends. It is my great pleasure to welcome you all to the CME, especially AMOGS and TNFOG always go hand in hand in organizing wonderful CMEs. And I welcome President of AMOGS, Dr. Rajendra Pardeshi, and also all the faculties. And the topics chosen today are also very, very interesting. And my friend Dr. Ragini is going to talk about antenatal maternal distress and perinatal outcomes.
Hello, madam.
It is going to be a very, very useful topic. And Dr. Kalpana is going to talk on surgical management of endometriosis, and there is going to be a case-based discussion on medical disorders of pregnancy. Definitely, this is going to give a lot of practical points, which I'm sure will benefit the practicing obstetrician. So I wish this webinar a grand success. Thank you very much.
Thank you, madam. See, I am Radhika is busy with the phone. I think I will introduce myself. I am TNFOG secretary, Dr. Sampath Kumari, and the Foxy vice president. No problem, Radhika.
Okay.
See, definitely, great welcome. And great welcome to our AMOGS President, Dr. Rajendra Singh, and Sujata's Madam for Secretary. With their permissions, we are going with the first Ragini Madam, as Revathi Madam told, Ragini Madam talk and Kalpana talk, everything will be very, very interesting. And AMOGS and TNFOG should continue doing the programs. Definitely we should have. See, now only the Infertility Committee and Medical Disorder is doing. I wish with the support of Rajendra Singh sir, we should do with all the committee and all the committees of AMOGS. So this is only a scientific influence for all our people. I wish all the success for the CME, and again for Kalpana and Sneka, I wish all the best. They both are really hardworking people. Both of them should come up. Thank you once again. Thank you, Rajendra Singh, sir.
Thank you, madam.
Thank you, ma'am. Sorry, Sampath ma'am. Thank you, Revati ma'am. Thank you, Sampath ma'am.
Thank you.
May I invite Dr. B. Kalpana ma'am. She is a gynecologist and infertility consultant, Guru Hospital. Her responsibilities are National Coordinator, Infertility Committee, FOGC, Chairperson, Infertility Committee, TNFOG, Secretary of AMOGS, Founder Secretary, Madurai Chapter of Tapisar, EC Member of Infertility Committee, FOGC 2017 to 2020. She is a South Zone Coordinator, Endometriosis Committee in 2014 and 2016. Organizing Secretary, AMOGS, Silver Jubilee Conference 2018. And she's the course director for postdoctoral fellowship in endogyne. She's a member of institutional ethics and principal investigator in clinical trials. An academic profile is she has been invited guest lecture in many national international conferences, and she's organized many conferences and laparoscopic workshops, and she's published more than 15 papers in national international journals, and she's been awarded the Best Doctor Award by Dr. MJ Medical University, Golden Excellence International Award by European Continental University, and she's won the Medical Excellence Award 2018 from Governor of Tamilnadu. And she's also been awarded the Best Medical Service Award from Madurai District Collector. Welcome, madam.
Thank you, Radhika. Actually, divine blessings and seniors' blessing give us great strength during this stressful period. Thank you, President Revati ma'am, Secretary General Sampath Kumari ma'am, for your blessings for the upcoming elections and the support you have been giving in these years. And it is actually two great federations, AMOGS and Tamilnadu Federation, come together to organize this wonderful CME, and two great committees, Tamilnadu Federation Infertility Committee and also AMOGS Medical Disorder Committee with its committee chairperson Sneha ma'am. Combinedly, we have organized this wonderful webinar under the guidance of AMOGS President Rajendra Singh Pardesi sir, AMOGS Secretary General Sujata Dalvi ma'am, and also our own President Revati ma'am and Secretary Sampath ma'am. So this is going to be a very successful program, and I request Sneha Bhuya ma'am to invite AMOGS President and Secretary for their blessings. Sneha ma'am doesn't need any introduction. She was a hardworking Best Committee Chairperson and now dynamic AMOGS Medical Disorder Committee Chairperson. Her dynamicity is seen everywhere daily, and she has received various awards, Anandibai Joshi Award, FOGC President.
Thank you. Thank you, Kalpana. Thank you. You can stop. Yeah. Chitrakala, you can stop sharing.
Yeah.
Yeah. So a very good evening, respected Dr. Rajendra Singh Pardesi, Madam Sujata Dalvi, Dr. Revati Janaki Raman, and Dr. Sampath Kumari, all our faculties today, especially Dr. Ragini Agarwal, and all the faculties, panelist, chairperson. A very good evening to all of you, and a warm welcome from my side too. This is a combined venture, and I just, without wasting much time, I invite my AMOGS President, Dr. Rajendra Singh Pardesi, who was the past Vice President of FOGC and the Committee Chairperson for Food and Drugs Medical Surgical Equipment Committee. And Sir has built up so much academics and has almost 20 to 30 national publications to his credit. But the most important thing is Sir is very, very cooperative, very humble, and a very helping hand for all of us. And he's a mentor for me to FOGC. So over to you, Sir, for your precious words.
Good evening, everybody. Respected Dr. Revati Janaki Raman, Dr. Sampath Kumari, Dr. Vijaya Lakshmi, Dr. Sujata Dalvi, Dr. Ragini Agarwal, Madam. My biodata start with Dr. Ragini Madam, as I was successor of Dr. Ragini Madam after Food and Drugs Committee. And she was my guiding force. And she is dynamic, as you think. And my office bearers and my chairpersons. First, I wish to congratulate Dr. Sneha Bhuya and Dr. Kalpana Balamurugam Dr. Radhika for organizing such an academic webinar and also for joining hands with each other, as Dr. Sampath Kumari told, for women's health. TNFOG and AMOGS, they are joining hands and hope this alliance will continue in future also. With the galaxy of speakers and chairpersons, panelists, this will be a great program. I wish every success to Dr. Sneha Bhoyar for her future endeavor in FOXI as Vice President election, and to Dr. Kalpana Balamurugam also for her election in as Chairperson of. Wishing every success to this webinar. Thank you. Thank you so much for inviting.
Sir, thank you so much, sir. You have been always guiding and blessing all of us. So thank you so much once again. And I invite Madam Sujata Darvi, our Secretary of AMOGS. And Madam is a senior consultant from Mumbai. Yeah, but I'm not going to read your CV, Madam, don't worry. We share the same emotions. Madam is very, very good human being, what I can tell you from my experience. And I just we are just eager to listen to your words, Madam. Over to you.
Thank you, Dr. Sneha. So as an AMOGS secretary, I would like to wish for today's program best success. And I would also like to express my gratitude to our AMOGS president, Dr. Rajendra Singh Pardeshi, who's always encouraging to have some scientific sessions like this. It's very fortunate that AMOGS Medical Disorder Committee, along with TNFOG Infertility Committee, are organizing programs one after the other. I would also like to express gratitude to TNFOG Office Bearers President, Dr. Revati, Dr. Sampath Kumari Secretary, and Dr. Vijaya Lakshmi Treasurer. I would also like to express my gratitude to the conveners of today's program, Dr. Sneha Bhoyar, Dr. Kalpana, and Dr. Radhika. And of course, we have an excellent speakers today, and we have excellent topics which are going to be covered. So I would like to wish for today's webinar best wishes, and I would like to wish Dr. Sneha and Dr. Kalpana best wishes for their future endeavor in FOXI. Thank you so much, Sneha. I think Sneha has got cut off or something.
Okay,
Yes.
ma'am.
Her net connection is poor, I think.
I think
So
looks
we go
that
with
way.
the session, ma'am?
Let's start off, yeah.
Okay. So the first session is the antenatal maternal distress and perinatal outcome. So I invite the chairpersons, Dr. Manish Gate and Dr. Shikari Lahani. Sir, Dr. Manish Gate, President of Chandrapur Obstetrics Society, 2023, West Zone Coordinator, Food Drug Committee FOXI, Secretary General ISOPAR, Vidarbha Chapter, Chairperson Women's Doctors Wing, IMA Chandrapur 2022-22. She's been the Secretary of Chandrapur Obstetrics Society in Maharashtra 2016-18, and she's the Vice President of IMA Chandrapur 2019 and Director of Chandrapur Test Tube Baby Center, recipient of National IMA Dr. Kanak Goyal Award for Safe Motherhood, Director of Santaji Mahila Nagari Sahakari Bank, Chandrapur, first to bring and start colposcopy in Chandrapur, invited as faculty speaker in state, national, international conferences. Areas of interest are laparoscopy, infertility, and colposcopy. And Madam works as consultant at Gati Surgical and Maternity Hospital, Chandrapur. Welcome, ma'am.
Thank you, ma'am.
And I also welcome Dr. Bharat Lanjewar, MBBS MD Obs and Gynae, FICOG, FICMCH. He is the president of Bandra Obs and Gynae Society, and consultant gynecologist and infertility specialist at Sahayog Hospital and Test Tube Baby Center, Bandra, and faculty of NDVH workshop at Kolhapur. Welcome, sir.
Manisha ma'am, can you please
Manisha, introduce.
our great
Yes,
speaker,
yes.
Ragini
Ragini ma'am.
Agarwal ma'am,
Yes,
who has
yes.
joined
Sure,
with,
sure.
great efforts. We are eagerly waiting for her talk. Please, ma'am.
Sure.
Please be very short. I don't want to be
But
spoken.
let me talk about you, Ragini Madam. Please. Good evening to all my respected seniors and dear friends. I bring warm greetings from Chandrapur, Maharashtra. It is a privilege for me to introduce Dr. Ragini Agarwal Madam. Actually, Madam does not require any introduction, but still I would like to quote few lines for her. She is the woman who takes a stand in every topic. And that's why I admire you, madam, every now and then. She is the founder president elect of North India Gynae Forum. She has been the vice president for FOXI. She is the founder president of Haryana Association of Gynae Endoscopy in 2017. And I am a Haryana chairperson for academics and public health education. Many awards are in her name. That is PJ Abdul Kalam Award for the Academic Excellence, Lioness Club Corona Warrior Award in 2020, IMA National President Award in 2021, and many more. With this, I request Madam to please take over the stage. Thank you for.
Thank you so much, Dr. Manisha, for your kind words and introduction. Very good evening to all of you. Today is a very different day because we have two great states coming together. AMOGS, which is if I can say, AMOGS is a society which has given me many insight for a close society, which is not on the national level, but a regional level. And it given me thought to make my own Haryana OBGYN society. So thank you, AMOGS, being a torch bearer for me. And Tamilnadu is a state which is very, very close to my heart. My son has get all medical education from the Tamil Nadu, and my two very, very dear friends, although friends are everywhere, but Dr. Revati and Dr. Rajendra Singh Pardesi, they are two people who are really after my heart. And thank you so much, Dr. Kalpana and Dr. Sneha, for giving me this opportunity, and especially giving me this opportunity to speak on a subject which, as a doctor, we never even think to talk. Am I able to share my screen or not?
Yes, ma'am, you can.
Yeah.
Ma'am, your screen is set to screen, ma'am.
Okay. Slideshow. So now it is there? Or it has
no, Ragini, you haven't shared your screen. First, share screen first. Minimize the presentation and share your screen.
Oh, I have shared it. I think it has not.
Have you allowed?
Now,
Yes, ma'am, allowed only, ma'am.
Yeah, it has come now. I think it has. Now you are able to see?
Yes, sharing.
Yes.
Just make it full screen.
Yeah, I'm doing it. I'm doing it. So this is something which is totally neglected when we talk about the clinical care for the stress during the antenatal period. Many a time we talk about the postpartum stress and postpartum blues, but we never say that this maternal prenatal stress, how it is going to affect the perinatal outcome. With the blessing of God and the gratitude to everyone who has contributed in this particular presentation, I'll start my talk with a quote that being a mother is learning about strengths you did not know you had a dealing with fears you never knew that existed. That is a mother. And stress is a trash of modern life. We all generate it. If you don't dispose of it properly, it will pile up and overtake your life. We all know about the Baker hypothesis. Not only this, we talk about this all the time, but have you ever thought of that, how this effect of the mother mental status are going to affect the growing fetus, not only as IUGR or future adulthood diseases, but is metabolic and brain development also. So it leads to a neurodevelopmental disorders, mood and cognition defects. When I talk about the antenatal care, for me, that clinical care comes at the last. First is a diet, then exercise, and to address the mental health of the woman. Because when you are making a baby, it is your responsibility to give a good atmosphere to that baby, even in utero. And we all today know that the in-uterus development of the baby occurs not only by that mother, but the mother of mother is also responsible for the development of the mother. So it is a generational changes which can affect the mental health, physical health, and the development of a baby when we do antenatal care. Prenatal stress, it was found that the majority of the research on the perinatal mood disorder has focused on the postnatal depression, the 50% of the cases. begin prenatally, over 30% of the cases, antenatal depression is a reason. Stress is a silent disease. Pregnant women need to be educated in recognizing when they have stress and the consequences, and some of the simple things they can do to make a difference. Who you are and what you are like when you are pregnant will affect who that baby is. It should be kept in each and every clinic. Women's psychological functioning during pregnancy, their anxiety level, stress, personality ultimately affects the temperament of their babies. It has to see the baby is awash in all the chemical produced by the mom. Physiological stress is a multidimensional factor that can be defined and measured by 3 dimensions. One is the stressful condition or event, individual perception of the stress, emotions such as anxiety. So this stress play a fundamental role in the etiology and evolution of disease and disorder. Neuropsychiatric disorders such as depression, autism, ADHD, and schizophrenia has a complex etiology which is influenced by the early experience that affect the vulnerability of the individual. The way the ADHD is increasing among the children is really scary. And the only thing which is common is the highly educated, Google-addicted mothers. During early intrauterine and postnatal life, the developing embryo undergoes complex physiological changes, and even a small disturbance can have far-reaching consequences, which can be observed into adulthood. So this effects of the prenatal stress, how it's going to work, there's a dysregulation of the HPA axis, leading to the alteration of the circadian rhythm, reduction of the hippocampal plasticity, and capacity of the learning and memory. It was very well seen in the COVID time when a person is under too much of the stress. There are so many cases of the increase in the mental health, and there's a changes in the hippocampal plasticity. There's many surveys. One very famous survey is the ALSPAC study, and it is an ambitious study aiming to gather the data, and its main objective is to study the interaction of the genes. So what they found that the high maternal anxiety during mid-pregnancy has been associated with the high anxiety as reported by the 8 and 9 years of the old offspring. Another literature scan has found that the difficult behavior, trouble to adapt to new context, and the crying in their toddler is again related to the high anxiety of the mother. Another paper supports that the more externalizing behaviors and the difficult temperaments in the 27 months old children when mother has anxiety during pregnancy. So regarding objective stress, it has been suggested that exposure to a high amount of the prenatal stressful events result in the children with increased fearfulness, even after controlling for postnatal confounding variables. A recent investigation with the low-income Mexican American mothers noted that the children exposed to the elevated prenatal maternal anxiety more likely display higher temperamental negativity, engage in less self-controlling behaviors. Not only this, maternal anxiety is associated with the increased risk of hyperactivity and inattention. It was found that these babies too active. So this ADHD is really becoming an epidemic-like thing. Every day, at least 1 or 2 babies walks in my room, and that children is so hyperactive. They are totally uncontrollable. Another study found that a better predictor of the difficulties with attention regulation and externalizing problem in the offspring than the presence of the objective stressors. The association with the pregnancy-specific anxiety and the poorer emotional and attention regulation has also been found. So what happened? There's a lifetime maternal stress. Maybe it is early childhood trauma, and there's a paternal preconception stress. We should never forget that a person has made by the 2 genes, one coming from the mother and another coming from the father. So these type of the insult, either it is maternal infection or maternal health improving behaviors, environmental contaminants, nutritional deficits with a genetic risk, lead to elevated pro-inflammatory cytokinins, elevated glucocorticoids, and altered maternal microbiome. Leads to the placental dysfunction, changes to the fetal brain, epigenetic changes, and adverse programming of the HPA axis. And what happened is there's a lots of obstetrical complication to lead to a premorbid risk factor in the baby, like cognitive, motor, and the behavioral defect. And in adult, there's an increased risk of the schizophrenia spectrum disorder. Maybe it is a mild, maybe it is a full-fledged. So a young adult having these type of the mental health problem, one cannot even think of it is coming from that mother who was not happy when that baby is developing in utero. So this psychological, physical, and the social stress with all hereditary information, with the influence of the environment, affect that fetus, leading to the behavior, cognitive, autonomic system. Everything is affected, leading to a maladaptive baby. And exposure to the prenatal stress has an important effect on the neurodevelopment effect, and this glucocorticoids is a main culprit. So this matter stress affect the heart, brain, and liver, and it has a lots of cardiovascular changes, neurological diseases, and the metabolic diseases in future in that baby. We talk about the metabolic disease in the baby, we talk about the adulthood disease of the cardiovascular system, but this part is rarely talked about a neurobehavioral disease, neuropsychological disease, neuropsychiatric disease, or the stroke in the baby. So this genetic landscape of the offspring interacts with the prenatal stressor to impact the epigenetic alterations. A number of the prenatal experiences are associated with the adverse outcomes of the birth, ranging from the cardiovascular problem to the psychiatric diseases. The defect is at the behavioral level, for example, increased fearfulness, or as a physiological one, that is brain structure and the functional changes. So primary mechanism is basically involve the fetal programming of the later outcome is the exposure to the maternal cortisol. High circulating level of the maternal cortisol during pregnancy correlate negatively with the birth weight, suggesting that the excess glucocorticoid can bypass the placental barrier. It is found that in the placenta, HSD2B2, it is a enzyme which is developed to prevent the maternal cortisol transfer to the baby. So that means the nature itself want to protect the baby, but if it is too much, like a sponge, it leaks to the baby and leads to all changes of the cortisol washing of the baby. So there's a linear relationship has been reported between the maternal and the fetal cortisol level. Relatively small increase in the maternal cortisol can double the concentration in the fetus. Another thing it is found that the first trimester, the placenta increases the production of the corticotropin releasing hormone, which regulates the duration of the pregnancy and the fetal maturation. This CRH is one of the most exciting recent scientific discovery that could explain why women go into the labor when they do. It is called placental clock. And this CRH level measured in the mother's blood early in the pregnancy between 16 to 20 weeks can predict the onset of labor months later. It was found that the maternal prenatal stress increased the glucocorticoid level, impaired 11B HSD2 activity. There's an increase in the placental CRH, and there's a dysregulation of the commensal bacteria influx. So it will lead to in the fetus increased glucocorticoid level, to the impaired maturation of the fetal HPA axis, imbalanced efflux of the commensal bacteria, and leading the skewed immune development of the toward TS2 predisposition, and increased risk of the development of the asthma of the offspring. So those with the highest level will likely deliver prematurely, and those with the lowest levels are apt to deliver past their due dates. So this high maternal cortisol in the pregnancy and inhibition of this enzyme programmed outcomes of the childhood, including high blood pressure, behavioral disorder, and the altered brain structure. So these all stressors lead to a stress perception and affect the immune, endocrine, and the nervous system of the baby. This might be the severe, moderate, or mild. What is a psychosocial stressor? Involves changes in the personal life, job status, housing, domestic violence, and the family makeup. And when we talk about the pregnancy-specific stress, even a mild anxiety in the patient doc, my baby will be okay, will leads to a effect on the baby. So the prenatal stress has an indirect effect on the maternal health, and maybe there's a direct effect. And this all lead to a compromised postnatal care, developmental changes, and the psychological dysregulation, leading to the lifespan, psychological, and the behavioral functions. Maternal stress and the inflammatory responses are altered during pregnancy. They are stimulated by stress and may be of sufficient magnitude. They could have potential to modulate the other aspect of the maternal health and the fetal development. So this blunted HPA axis under the stress response leads to immune system and favors the anti-inflammatory response. Activation of the that is a normal thing, but here activation of the HPA and the inflammatory response during pregnancy can affect the maternal health during and the beyond pregnancy. The stressed mothers are more susceptible to infection, illness during pregnancy as a result of the suppressive effects of the stress on the ability of the immune system to respond to the challenge. It is found that 8% to 13% of the women are diagnosed with anxiety or the depressive disorder, and it might be just a tip of the iceberg. Even women with the subclinical symptom of the depression and anxiety during pregnancy that do not result in a diagnosis have an increased occurrence of the premature birth. So the perinatal mood disorder are more common in women who report the high level of the life event stress, and poorer postnatal care, including reduced duration of the breastfeeding, impaired mother-infant interaction, and delays in the infant behavioral development. This pregnancy and birth complication, if you see, it goes from the preterm delivery, preterm labor, LBW, shortened gestational length, preeclampsia, and gestational diabetes, which otherwise have a bad effect on the baby. So this stress acts as a teratogens, which is proved in the many literature. And long-term effect of the perinatal distress is a preterm birth and the low birth baby, regardless of the root cause, can result in the lasting deficiencies in the infant behavior and physiological development and the function. They are more likely to experience asthma, allergies, and may also experience more severe health conditions which require ongoing medical treatment throughout the childhood. 70% of the infant perinatal deaths are related to LBW, PTB, and restricted fetal growth, and who survive, they have the greater risk of the physical and the developmental delays in the later year. So prenatal stress appears to stimulate activity of the maternal endocrine and the immune system, leading to the PTB and LBW and the shortened gestational age. Women experiencing preterm labor have elevated levels of the inflammatory cytokines compared with women who deliver normally, and the lymphocytes of the women delivering preterm produce more inflammatory cytokines in the culture. Psychosocial stress and the pregnancy-specific distress are associated with the elevated serum levels of the inflammatory cytokines. Women who encounter psychosocial stress, as I already told, that there's a high level of the CRH and the cortisol. So stress and the HPA axis activation have also been implicated in the development of the other complications during pregnancy, such as preeclampsia and gestational diabetes. Lifespan affects the human health, and the development associated with the prenatal stresses are attachment difficulties, stress hyperresponsiveness, asthma, allergy, difficult temperament, and the affective disorders. It affects the cognitive performance at the 5.5 years of the age. Even it was found that the risk of the factor of the schizophrenia are more frequent in the offspring of the mothers who endured the storm during their pregnancies. Exposure of the developing fetus to stress hormones resulting alteration in the neurobiological development are responsible for the behavioral development. So in short, the prenatal stress induces the release of the glucocorticoids, enter the fetal circulation, gain access to the developing nervous system, leads to the neurons in the developing hippocampus, express the high number of the glucocorticoid receptor, and the cognitive and the memory impairments observed in the offspring of the stress pregnancies. So increase in the stress hormones in the fetus induced by the maternal stress after hippocampal development by binding to these receptors and either have a neurotoxic effect or disrupt development in other ways, such as the reduced dendritic arborization. So when you listen these things, a small stress can change the whole life of that growing fetus. It is so important to address this stress at the time of booking when the patient comes to you. Human studies are showing persistent and the functionally relevant changes in the immune function of the offspring in the stressed mother. Gestational stress experience the allergy, asthma, and lots of adulthood problem otherwise. And this also lead to the illustration in the co-regulation of the endocrine and the immune system. There's an increasing data suggests that the racial stress is a contributor to the persistently higher rates of the LBW infant mortality found in the African American women compared with a white woman. Researchers have found that although many prenatal behavior as smoking, hypertension, and pregnancy are risk factor, Caucasian and African American woman exposure to stress is sometimes only productive for this LBW. So the concept of stress is multifaceted. An individual's experience of stress during pregnancy are influenced by not only by the stressors themselves as described, but also by the cultural, social, and the environmental context in which the stressors occur. So future direction, these are the few questions which I want to ask. What type and the degree of the prenatal stress have an effect? What are the gestational age of the vulnerability? What are the range of the effects on the child? How does the prenatal stress interact with the genetic vulnerabilities? How are the effects of the prenatal stress moderated by the nature of the postnatal care? How do outcomes vary with the different ethnic groups and in different parts of the world? More research is really required to prove this mechanism. To conclude, psychosocial, cultural, and the environmental stressor experience during gestation can be detrimental to pregnancy and the maternal and the fetal health. Prenatal stress can have consequences that span generation. May occur directly to the influence, or there's an activation of the maternal stress response resulting changes in the endocrine and inflammatory activity. Take-home message is, if we want the best outcomes for our children, we need to provide the best possible emotional care for pregnant women. There need to be more public health education about this issue, and pregnant women encouraged both to look after themselves emotionally. At present, most anxiety and depression in pregnant women is undetected and untreated. We need to make sure that pregnant women are sensitively questioned when they first come in the contact with the health professional about their emotional history and current status. Even this stress comes with your mother's milk also. Thank you so much for this opportunity and the patient hearing. Smile, breathe, and go slowly. Thank you so much.
Thank you, madam, for such an explanatory and elaborative talk. You have very nicely emphasized the importance of maternal mental health in the prenatal period, especially the stress which affects the fetus. So we should always concentrate on the prenatal mental health of the woman whenever she walks in the OPD for the ANC care towards us. Thank you. Thank you so much, ma'am.
Thank you so much. Thank you.
The in-law should keep them stress-free.
Yes, ma'am.
Thank you, madam.
That stress is also breastfed to the child. Thank you, ma'am, for your elaborate talk.
Thank you so much.
Thank you, ma'am. That was a lovely session, and it was from a different point of view. And almost all our children, probably obstetrician children, would have experienced this stress, I think. And the next session is surgical management of endometriosis. And I invite the chairpersons, Dr. Shefali Jain and Dr. Manoj Agalve, to introduce Dr. B. Kalpana ma'am, chairperson, Infertility Committee, FOGS. Dr. Shefali Jain is a consultant and head of the Department of Obs and Gynae, BJ Hospital and Research Institute Private Limited, Ganesh Nagar, Gondia, Maharashtra, since last 20 years. She's done her MBBS from JNM Medical College, Raipur, MD from SS Medical College, Reva, and she's had her laparoscopic training from Cochin under Dr. Hafiz Rahman, and ultrasound training from Mumbai. She worked as a consultant at GKNM Hospital, Coimbatore, and she's been the ex-secretary of FOGSI Gondia, present president of FOGSI Gondia. Her field of interest is high-risk pregnancy, infertility, gynecology clinics, menopausal health, working for public awareness in schools and colleges. Madam, Dr. Shefali Jain, welcome. And Dr. Manoj Agalbhay is a consultant laparoscopic surgeon and infertility specialist at Siddhi Vinayak Hospital, Lakani, Bandra, and he's the secretary, Bandra Obs and Gynae Society, and ex-assistant professor, IGGMC, Nagpur. Shefali ma'am, can you please introduce Dr. B. Kalpana ma'am, who is the speaker for this interesting session? Shall I? Hello, Dr. Shefali ma'am. Hello, Dr. Shefali ma'am.
You can introduce me shortly. So
Okay, ma'am. Dr. B. Kalpana madam is the chairperson Infertility Committee for FOGC, and she's done her MBBS, MD, OG, and fellowship of reproductive medicine, FNB in reproductive medicine, PhD, FICOG, FIAOG, and FICS. And she's a gynecologist and infertility consultant at Guru Hospital. Her other responsibilities are she's the national coordinator of Infertility Committee, chairperson Infertility Committee, TNFOG, secretary of AMOGS, founder secretary, Madurai chapter of the PISAR, EC member of Infertility Committee FOGC from 2017 to 20, South Zone Coordinator Endometriosis Committee 2014 to 2016, and she's the organizing secretary of AMOGS Silver Jubilee Conference, course director for postdoctoral fellowship in endogynae, and she is a member of institutional ethics and principal investigator in clinical trials. She's been invited as guest lecturer in many national and international conferences, and she's organized many conferences and laparoscopic workshops. Okay.
Thank you so much for your kind words.
Thank you, ma'am.
Can you see my slides, Radhi?
Yes, ma'am.
Good evening, everyone. It's my pleasure to be part of this wonderful webinar, and with the blessings of our great seniors, I just go into the topic proper. The topic of discussion today is surgical management of endometriosis. We all know that endometriosis, even now, it remains an enigma. The symptoms do not correlate with the severity of the disease. Many a times, the treatment modality varies from patient to patient. So, the incidence of endometriosis in general population is almost 5%, but in infertile population, it is almost 50%, 10 times increased. And many a times we diagnose empirically with the typical features of triad of symptoms like pelvic pain, dysmenorrhea, dyspareunia, which gives a clue that the patient may have endometriosis. But sometimes typical ultrasound pictures of endometrioma, which cannot be missed even by a beginner, can help us to diagnose endometriosis. Sometimes if a patient comes to us with bowel symptoms, probably transrectal ultrasound can also be helpful. Yeah, if it is bladder or bowel involvement, sometimes even we need MRI confusion about endometriosis. Previously, endometriosis was diagnosed with the previous ESHRE guideline says that histopathological examination is really needed, but now it is not really needed. If we suspect endometriosis, even in adolescent girls, we can go for empirical treatment of oral contraceptive pills or GnRH analogs to confirm that even that trial confirms that she's having an endometriosis. So, if we have decided for surgery for various reasons, the aim of surgery is to reduce the endometriosis disease burden, which would definitely reduce her symptoms and also restore fertility. At the same time, we should plan in such a way that she doesn't have recurrence in the recent years. When a patient comes to us with endometriosis, especially for pain, if medical treatment fails and if she's not bothered about infertility, then medical treatment should be the first choice. If medical treatment is not helping her, then surgical treatment can be taken, and surgical treatment again we need to reduce the disease burden by removing the endometriotic lesion, and the pain could be due to adhesions that should be reduced, and sometimes it is because of interrupted nerve pathway which has to be taken care if these other modalities are not helping her. Restoration of anatomy is really needed in these patients. So the goal is not always surgery. Adolescent girls, medical treatment should be the first choice, and but in reproductive age group, and especially if she's infertile, bothered about her fertility, and she wants to conceive immediately. She's having symptoms, severe symptoms like pain. She's a candidate for surgery. But at the same time, always remember that first surgery should be the best surgery and in the expert hands, and so that the recurrence can be reduced. Multiple surgery should not be planned, and because it would reduce her ovarian risk. So endometriosis can be superficial, or superficial can be peritoneal, or sometimes ovarian endometriosis, deeply infiltrating endometriosis. It is really difficult to treat deeply infiltrating endometriosis. We can go with various modalities like laparoscopy, laparotomy, or vertically assisted surgery, whichever way we are comfortable, and the equipment which is available in the hospital. So when we are doing diagnostic laparoscopy, we should always look carefully for endometriosis, because many a times it is missed in 70% of patients, and 50% of patients it is underdiagnosed. It is really essential to diagnose endometriosis because it is a progressive disease, and the progression rate is almost 3% per year. So each year the pregnancy rate comes down by 10%, and pain is also reduced if we treat the patient surgically. This is a Cochrane review which concluded that when we plan for laparoscopy, we have a dilemma which way to go, either excision, ablation, which is better. But Cochrane review concluded that even excision or ablation are comparable, and definitely it would reduce the pain or other symptoms in a patient with endometriosis. So it can be done with excision can be done with scissors. The thing is, we get specimen for histopathological examination, but multiple sites of raw area, hemorrhagic area is difficult to manage. Sometimes destruction can be done with unipolar, but at the same time, deep lesions cannot be treated with unipolar. There is a risk of damage to underlying structure. Bipolar can also be efficiently used. This is a conclusion from RCT, which concluded excision, ablation are comparable, and there is no studies comparing laser, ultrasonic, or robotic about the superiority of one over the other. So, if a patient is having mainly midline pain, then she can be considered for interruption of pelvic nerve. When we think about interruption of pelvic nerve pathway, we have the options of LUNA or presacral neurectomy. But as far as the evidence is concerned, LUNA is not very effective in reducing the pain. But at the same time, presacral neurectomy can be considered in these patients. But at the same time, always remember that presacral neurectomy needs a great skill, and at the same time, always counsel the patient about the disadvantages or side effects of this surgery, especially constipation, sometimes urinary urgency, painless first stage of labor. Coming to non-cystic ovarian endometriosis, that is peritoneal endometriosis, as we have already discussed, it can be ablation or excision. The next one is ovarian endometrioma. When we have ovarian endometrioma, the first and foremost choice is excision of the cyst wall rather than aspiration, because aspiration would increase the risk of recurrence and the symptoms are not significantly reduced. So excision of the cyst wall should be the choice for these patients, because it has been proved that there is a significant reduction in the symptoms and the recurrence is also significantly reduced. So always whenever you are planning for a surgery in a patient with endometriosis, always think about extensive adhesions, bladder adhesions and bowel adhesions. It need not be always a simple endometrioma surgery. And if you are planning for cyst excision, proper plane should be identified, because if you go in, if you are not going in a proper plane, you tend to have more bleeding, and excessive use of thermal energy would definitely reduce our ovarian reserve. At the same time, when you are going near the hilum, be careful about the primordial follicle, which are pulled up in the hilum area, which would, if you use excessive thermal energy at that point, you are going to reduce her ovarian reserve. So coming to infertility, in stage 3 and 4 endometriosis, it is quite obvious that these patients do have tubal factor, which could be the reason for infertility, because tubo-ovarian anatomy is altered in these patients. But in minimal and mild endometriosis, various hypotheses have been put forward. It could be due to salpingitis, which can affect the ovum pickup into the tube. Sometimes it may be an inflammatory disease. Inflammatory markers are increased in these patients. Maybe the phagocytosis of the sperms could be a reason for this infertility. Egg-sperm interaction is also affected. And sometimes it may be an immunological reason. Various antibodies are formed against, and also uterine receptivity is also significantly reduced in these patients. These could be a reason for infertility in these patients. So when a patient comes to us with stage 1 and 2 endometriosis, if she is bothered about her fertility, and lap surgical removal of endometriosis will definitely improve her fertility. That has been proved by World Endometriosis Society also. But stage 3, 4 and deep endometriosis, we need future trials also. When a patient comes to us with colorectal endometriosis and deeply infiltrating endometriosis, we need to think twice before going for a surgery, because surgery is not going to be very simple surgery, and it is going to have various complications. Even if we have a team of gastroenterologists and urologists together, we tend to have many complications in patients with deeply infiltrating endometriosis. Always after a surgery, if a patient is infertile, we need to utilize the precious period period of first 6 months, which is the potential period where the patient can conceive with various modalities of treatment, whatever may be the treatment. But if we miss that period, and if we don't, if we tell her to try naturally, if we are losing that precious period in few years, she may come to us with recurrent endometriosis. So if a patient comes to us with recurrent endometriosis, we have a dilemma whether to go for a surgery or IVF. It has been proved by various trials and reviews that repeat surgery would reduce her possibilities of pregnancies by 50%. So IVF should be considered in these patients. So the next dilemma is a patient coming to us with huge endometrioma, and she has been decided for IVF because of various reasons. Could be a tubal or could be a male factor. Should we operate her that endometrioma before IVF is a dilemma. But various guidelines had recommended that it is better not to go for laparoscopic surgery if a patient has been decided for IVF, because each surgery is going to reduce her ovarian reserve. So the surgery is really indicated if a patient is really symptomatic with severe pain and huge endometrioma, and all the follicles are almost behind the endometrioma. If we feel that it is difficult to reach the follicle to get the eggs out of that, in that occasion, we can do surgery, remove the cyst, not at the intention of improving the pregnancy rate, but at the intention of better accessibility of those follicles which are sitting behind the endometriotic cyst. What is the role of medical adjuvant therapy in these patients before going for surgery is another dilemma. Actually, preoperative medical therapy should not be given in a patient with endometriosis who is going for endometriotic surgery, because your medical therapy is going to mark the lesion and at the same time it would increase the recurrence rate. But in a cases of severe endometriosis where you think that surgery is going to be very difficult, in that occasion, medical adjuvant therapy may be helpful, because Cochrane review has concluded that it may reduce the endometriotic implants, and we can go for a surgery, but at the same time, medical therapy would increase the recurrence rate. This is possible in case of severe endometriosis, where sandwich therapy is better. Medical treatment, surgical treatment, and post-operative medical treatment may be useful, especially if the patient is having severe symptoms like pain. So what about the role of post-operative medical therapy? Again, it is useful in a patient who is coming to us for pain and not for infertility. In that occasion, post-operative medical therapy may be useful to reduce the recurrence, and it has to be continued for years together to reduce the recurrence. That has been concluded by various studies. But at the same time, if the patient is particular about her fertility, then there is no role of post-operative medical therapy, because we are missing out the precious period in which she can conceive by various modalities. So post-operative hormonal therapy may be useful in patients with pain, but not in infertility. So when do we go for definitive surgical intervention? When the patient is in severe stage and the medical treatment is not really useful and she has completed childbearing, then she's a case for radical surgery. Always local excision, sometimes in 80% of patients, there is a recurrence, and hysterectomy with ovaries preserved. 96% no further surgery is really needed. So Luna, we have already discussed post-operative medical treatment could be GnRH analogs or even long-term LNG IUD can be helpful in these patients. So repeated surgery, especially in infertile patients, should be avoided because it may reduce her ovarian reserve. Deeply infiltrating endometriosis may be anterior at that time. We may need to go for partial cystectomy. If it is uterosacral, vaginal, and intestinal, we need to go for a resection. So proper counseling of the patient is really needed. Proper consent is also really needed, because it may be associated with various complications like fistula and leaking. All those dreaded complications are quite common in these patients. Colorectal endometriosis, we have the options of shaving, resection, segmental resection. Out of that, segmental resection is always better compared to all other modalities. At the same time, counsel about the possible dreaded complications, which may be sometimes life-threatening. Also, always counsel a patient before taking a patient for surgery. There is a possibility of recurrence, because the disease is a progressive disease, and recurrence is almost 40% over a period of 5 years. Bladder endometriosis may need a resection. Sometimes always think about ureter, which may be displaced. So displacement of ureter is always better when you are planning for endometriosis surgery. So definitely surgery would improve the pain and quality of life, but at the same time, call for help, call gastroenterologist and urologist if you suspect extensive adhesion, and at least alert the other specialty doctors, and you go ahead with the surgery. If you need a help, don't hesitate to call others, because it is going to be a teamwork, and always counsel the patient about all other complications, fistula, ureteric injury, and recurrence. All those complications should be counseled to the patient. So should we go for surgical therapy with ART? Again, it is not really needed. If we are planned for surgery by ART, surgery before endometriosis surgery is not really needed, because each surgery is going to reduce her ovarian reserve, even in the hands of experts. So don't counsel a patient for surgery if you have already decided for ART in these patients. Even surgery in deeply infiltrating endometriosis, if she has been planned for ART, surgery doesn't have a great role. In recurrent endometriosis, again, IVF is the standard treatment, and there is no role for repeat surgery, because repeated surgery would reduce her ovarian reserve. So to conclude, endometriosis has a deep impact on the practice of infertility and gynecology. So it should be our endeavor to pick up in earlier form, offer conclusive surgical treatment, and follow these patients with a targeted treatment as indicated by her age, stage of disease, and male and female factors. Thank you.
Thank you, madam. Thank you, ma'am. That was a wonderful presentation, very practical. We now move on to the next session, which is the panel discussion, case-based discussion on medical disorders of pregnancy. I invite the moderator, Dr. Sneha Boyer, ma'am, AMOGS chairperson. And Dr. Sneha ma'am has done her MBBS and MD, both from BJMC and Sassoon General Hospital, Pune, Managing Director, Sukharta Hospital, Maternity, Surgical Nursing Home, Laparoscopic and Infertility Center. 29 years of experience in this field, and she has teaching experience of 5 years in SVN Government Medical College, Yavatmal. And she has numerous awards and accolades. National Individual Award FOGSI 2008 for outstanding work in rural obstetrics. Dr. Anandi Bhai Joshi Award by Government of Maharashtra in 2005. FOGSI President Appreciation Award for Public Awareness in 2018. FOGSI President Appreciation Award for Exemplary Work in Cancer, WOW 2019. Champions of FOGSI 2019. International MS Signature Award for Phenomenal Leadership 2020. Lokmat Healthcare Excellence Award 2020. and Asia GCC Award for Leadership in Healthcare 2021, Champions of Oxy again 2021, National Expert at UNICEF, and Lead Assessor Foxy Manyata. And she has held the following official posts: Chairperson of Breast Committee in Foxy 2019 to 21, and Governing Committee 2021 to 22, Chairperson Medical Disorders Committee, AMOGS 2022 to 24, Founder President Vidarbha ISOPAR 2017 to 19, President YUGS 2007 to 8, Founder Clinical Secretary of YOGS in 2003, Executive Committee Member AMOGS 2020 to 22. And she has given numerous talks and has many publications, more than 300 talks in state, national, international conferences, and 25 articles and chapters in national.
Thank you. Thank you, Dr. Gauri. Thank you so much. Chitakala, you can stop sharing and please allow me to share my screen. A very good evening to all of you once again. And I take this opportunity to be with all of you and try and share the knowledge. Rather than, I think this is quite an old CV. I have completed my 30 years of my experience now, 31st year, and the publications have reached to more than 30. So thank you so much. Thank you so much. I once again thank all the organizers and especially Sampath ma'am and Revati ma'am and Kalpana. And I welcome all my panelists here, Dr. Manisha Vasade. Do we have Dr. Manisha? Can you see my screen? Can you see the screen?
Yes, ma'am, but not in the slideshow, ma'am.
You can see.
Okay. Can you see it in the slideshow now?
Yes, ma'am.
Right?
Yes, ma'am.
Okay. So do we have Dr. Manisha Vasade here? Dr. Bansi? Dr. Bansi Shinde? Kalpana, did you make calls to these people? Have they joined or are they going to join? Dr. Poonam Nagrare? Dr. Poonam?
I think.
Yeah, I could see somebody here. Yeah, Dr. Poonam. Dr. Manisha Vasade, Dr. Poonam, are you here?
Poonam is
Poonam, yes. Poonam, yes, I can see. And Dr.
Yes, ma'am,
Manisha, please.
Yes, ma'am, I'm there.
Good,
Yeah,
good.
I'm here.
Hello,
Yeah.
hello, Manisha. And
Yes, good evening,
Dr.
ma'am.
Vasanta Kumari, Dr. Sujata Allagesan, Dr. Jasmine Rajesh.
Jasmine is there.
Jasmine is there. Can't see Dr. Jasmine. Can you please just show your video, Dr. Jasmine?
Raised her hand.
Okay. So Dr. Parag Mahajan has messaged me. He has lost some close relatives, so he will not be able to join. Yesterday night itself, he messaged me. So I welcome all of you here. Dr. Jasmine, you can unmute yourself, please. You can unmute yourself. Yeah. So without much ado, we go ahead with the panel discussion on medical disorders of pregnancy. And friends, all of you know that medical disorders of pregnancy are very, very important, and of which many of these, they are the major causes of direct maternal mortality. And as you will agree to me that pregnancy itself brings about profound physiological changes in the body, putting additional load on the various systems. And on top of this, if the lady has pre-existing comorbidity, like medical disorder, it poses the woman at additional risk. So medical disorders which are commonly dealt with, anemia, heart disease, hypertensive disorders of pregnancy, hyperglycemia of pregnancy, and thyroid dysfunction, or maybe some of the liver disorders and febrile illnesses you may have to tackle during the course of time. So we come to the first case, Dr. Manisha. Manisha Vasadi. So we have this third gravida, para 2, with 3 months amenorrhea. She comes to you with complaints of weakness, easy fatigability, and mild breathlessness. There's no complaint of pain or bleeding, and when you examine her, you find her vitals are stable, her abdomen is soft, non-tender, 3 months pregnancy. When you do her, she has a basic report of hemoglobin, which is 5 grams per cent. That's the reason she has come to you. What is your diagnosis here? What is the class or severity? What investigations you want to do for this lady, and how would you go ahead with the management part of it?
So,
Yes.
good evening, ma'am. Thank you for giving me this wonderful opportunity. Thank you, Sneha ma'am. This case, we are dealing with a case of ANC with severe anemia. So,
Correct.
first of all, I would like to investigate her basic investigations, like complete blood count has to be done just to know the type of anemia she is having. And then we would like to also rule out whether she is a sickler or not, because she's having some
Yes.
sort of blood, this thing. So we would like to do her HB electrophoresis or HPLC, which will give us the diagnosis of which type of anemia she has. Then also her PS peripheral smear has to be done to see whether she's having some parasitic infection or some sort of infection which is leading to severe anemia. And after diagnosing what kind of anemia she has, then we can further manage such kind of patient.
Okay. So on complete blood count, what all information do you get? Do we have Dr. Bansi Shinde here? No. So you can continue with the discussion. What all information do you get on complete blood count? That is hemoglobin, hematocrit, and what else?
Hemoglobin, hematocrit, and reticulocyte will do. Also, from the reticulocyte count, will come to know whether if it is increased and decreased. If it is increased, then it is mainly the mean corpuscular volume. If it is low, then it is a microcytic anemia, and if it is bigger one, then it is a macrocytic kind of anemia. Also, red cell distribution width will come to know the type of anemia she has. So after seeing all the parameters, we'll have to correlate the parameters and then come to a conclusion which kind of anemia she's having.
Yes. In addition to this, if she has any infection, the leukocyte count, the total and differential will also be altered. And if at all she's got thrombocytopenia as a part of generalized, cellular hypoplasia or bone marrow hyperplasia, you will be able to know the cellular morphology. And as you have very correctly pointed out, if it is a small size microcytic hypochromic, then label it as iron deficiency anemia. So Manisha, do you think that there can be, a peripheral smear showing a picture of? Now we're coming to the peripheral smear. One point we have forgotten in the peripheral smear. You have just said maybe you can, get to know the type of cells, but can you get some additional information on peripheral smear? You can get the information of hemolysis. If you see the fragmented RBCs on peripheral smear, you can get the information that this can be a hemolytic anemia as well. Okay. Yes, so microcytic hypochromic anemia, if you have this picture, yes, Dr. Jasmine, you can take up this question, what I'm trying to ask. That on peripheral smear, you have a picture of microcytic hypochromic anemia. So is that sufficient to know or label this patient as having iron deficiency anemia? If not, then what are the other investigations? Please let me know.
We should go for a serum iron, madam, total iron binding capacity, and we can go for a serum ferritin and other investigations.
The reason being, why do you suppose you have a clear-cut picture of iron deficiency? Then why do you want to go for iron profile?
Madam, we should know how much of the reserve iron is there for the patient, and we'll try to know the total iron binding capacity of her also.
That is one aspect that we'll get to know the severity and what phase of anemia she has. But then, is there any information? See, you have certain patients who is showing you microcytic hypochromic type of anemia. But when you do the serum iron profile, the iron stores are in fact more. They can be even iron overload. So what are these cases? What are these cases? Yes, perfect. They are the thalassemias. The thalassemias present like this, that when you do the peripheral smear, you feel that it's a microcytic hypochromic type of anemia. In fact, when the patient is in iron overload. So if you give iron to such patient, it will create havoc. In the patient will end up into complication. So to know whether it is truly iron deficiency or it is the, iron overload, and that is because of the thalassemias, you have to either go for hemoglobin electrophoresis, and along with this, you have to go for the iron profile. Okay, so all these investigations to know the type of anemia, the severity of anemia. Now, how do you manage this patient early? Dr. Poonam, how do you manage this patient? Early pregnancy with severe anemia.
Ma'am, she is of the early pregnancy with severe anemia, and she being in the first trimester, she is having GI intolerance or GI disturbance.
Yes, but for severe anemia, how do you treat her? Yes.
For severe anemia, we go for blood transfusion.
Yes. So the message is very clear here. Severe anemia, anytime during pregnancy, labor, delivery, you have to go for blood transfusion, especially when this patient, when she's symptomatic, she's actually breathless and she's having easy fatigability. So you have to go for the blood transfusion. Now, once you have given her blood transfusion, how do you correlate and how do you maintain her iron stores? The question here is whether she has directly landed up into this severe phase or there are various phases through which she has to go through. So, Dr. Sujata, do we have Dr. Sujata here? Do we have Dr. Sujata here? No. So, Dr. Poonam, you can continue with this, that does the severe anemia develops all of a sudden, or you have various phases of development of anemia?
Ma'am, it develops, it is not the sudden development of severe anemia. It comes in stages. Initially, we have to identify her in the mild or moderate phase. And in those cases, in mild cases, we can go with oral supplementations.
I'm talking before the clinical presentation. Does she have any other phases? That means initially the iron store get depleted, that you get to know by doing the serum iron levels. The patient is absolutely asymptomatic. Here, the patient is absolutely asymptomatic. When you do her serum ferritin levels, then you come to know that her serum ferritin levels are very low. A percentage saturation also has fallen down, and now this patient has started developing iron deficiency. So first stage is depletion of iron stores in the bone marrow, in the liver and spleen. And if you detect at this stage, you can just replace the iron stores so that she does not develop the frank or overt anemia. Now, if you miss at this stage, maybe then her serum iron levels fall, then her hemoglobin starts falling at a later stage, and when it becomes severe, then she becomes symptomatic. So that is what the various phases of anemia are. So before it becomes clinically evident, the patient has so many opportunities we can treat her. So if you properly evaluate her, then only we'll be able to know what are the stages and at what stage, what action you have to take. So we don't have Dr. Parag Mahajan here. So we will just go with the next panelist, that is Dr. Jasmine and Dr. Poonam, of course. So we have Dr. Poonam, Manisha, and Dr. Jasmine. Is that only 3 panelists? Do we have somebody else? Okay, so Dr. Jasmine, when should we screen these women? Rather than landing up into pregnancy with severe anemia, how should
we can start screening the first trimester itself, ma'am? Because nowadays we are doing an early AMC registration, and the basic screening of these ladies in the first trimester will be more fruitful, because you can avoid severe anemia, which is leading to abortions and all such things. So better to screen them in the first trimester itself.
Whether it is the first trimester or the very first point of contact, that is the first antenatal care visit.
Yeah, that we can even proceed with the first visit itself.
Yes, that is what. So as baseline, we have to do certain investigations. But given an opportunity, would you like to screen her little earlier, maybe pre-conception, maybe premarital, and even the adolescents. So what are the guidelines? Yes. What are the guidelines by Government of India? When should we screen them?
So it can the first visit, next following at 20 weeks, then 24 to 20 weeks, and finally towards term 36 weeks.
Yes. So ideally, we should screen them at the very first point of contact. And then, as you rightly said, 16 to 20 weeks, 24 to 28 weeks, and 34 to 36 weeks. So before delivery, the patient is all set and ready to undergo the stress of labor. So ideally, as we have said, that it should be actually a preconception screening and given an opportunity premarital, because nowadays we are talking much about the hemoglobinopathies. They're becoming very, very common. And maybe even though it has not come in as recommendations, because we are having these problems quite frequent and going it to quite serious level, we are doing it as a routine. The hemoglobinopathies, hemoglobin electrophoresis and HPLC, whatever is available and accessible, you're supposed to do for it. So we go to the next case now. Dr. Manisha, this is a case for you. You have this unregistered primary gravida married for 2 years, and she comes to you with 9 months amenorrhea. She's unregistered. She comes to you with mild pain in abdomen, mild discharge per vaginum, fever, cough, breathlessness. When you examine, you find that she's got tachycardia. There's no pedal edema, but she was having mild pains, and suddenly, under observation, she gets PROM, premature rupture of membranes. So you thought of augmenting her, started with augmentation with oxytocin. Suddenly she developed fetal distress. So you have to take a decision for cesarean section. And when the anesthetist examined her, he finds a diastolic murmur. So what is your diagnosis for this patient? Whether you could have diagnosed this earlier and you could have prevented this mishap or emergency? Yes, please let me know.
Ma'am, she is after seeing with her history, we come to know that she's a case of cardiac disease, and
how you came to the conclusion?
Indicates that she's a case of congenital heart disease, which is maybe
not necessarily. It can be mitral stenosis, which is very, very common. Having a diastolic murmur is a sign of organic heart disease. We totally agree with you, but it can be either congenital or acquired. And the most commonest being, because she has reached to this adult stage, never diagnosed, never manifested, so it may be a rheumatic heart disease. Yeah.
So it could be a rheumatic heart disease. So such patients, we could have diagnosed this patient earlier also, but since she is an unregistered case, if she would have come previously to me, I would have definitely auscultated her and diagnosed her in early stage of her pregnancy. And
yes. But here, even when she came to you as emergency, at the first visit itself, you have to examine her all the systems, including respiratory system and cardiovascular system. So not to forget to put a stethoscope on the chest and look for any murmur. Yes.
So now how to manage? So now she has come to me. She's already delivered and she is breathless. So I'll have to give her immediate management, like we'll give her proper position. We'll give her oxygen, and
she's in pulmonary edema.
She has developed fetal distress now, and we are taking her for cesarean section.
Yes, she has baby delivered, and baby has been delivered.
No, we are taking her up for cesarean section. So the anesthetist detected the diastolic murmur. Now, because this was a question whether you could have prevented. She was given regional anesthesia, the baby is delivered, and suddenly now she started becoming breathless. So at this point of time, what is your diagnosis? And why she has developed this?
Going for pulmonary edema.
Yes, yes, you're right.
Pulmonary edema.
Yes. So the physiological changes right from early pregnancy, they start by 6 weeks, they reach the peak at 32 to 34 weeks. but these are the patients who are prone for going into failure, cardiac failure during labor, immediately after delivery and the first week following delivery. So this is the most vulnerable period, that she has just delivered and suddenly she started becoming breathless. So that is most likely congestive cardiac failure or left ventricular failure. Okay, that is pulmonary edema. So what precautions you should have taken for this patient while managing even intraoperatively? What all things about oxytocics, about IV fluids? Yes.
Yeah, we could have restricted the IV fluids to her, and then instead of giving methergine, we could have given oxytocin or else carbetocin, which is the newer drug, which is more potent than oxytocin also. And
so the concentrated infusion of oxytocin or carbetocin.
Carbetocin, yeah, yes, that could have been given, and that would have prevented her loss of fluid. And
okay, anybody else wants to add anything here?
We can
We
give
would like to give her diuretics also.
Diuretics, yeah.
Perfect, perfect. So because see, even when the baby is inside, we want to restrict the use of diuretics, but when the patient is prone for failure, then these are the situations where you have to go for the diuretics, so that there's no load on the heart and she doesn't go into cardiac failure. So here we have our patient who we feel that she's a case of rheumatic mitral stenosis, most probably, though because you do not have the diagnosis beforehand, you may think of all this because these can be the possible causes as well. And this is just for theoretical discussion, which we do not want to do. This is a functional classification of heart disease, that is New York Heart Association, as this patient was having the symptoms even with the rest. At this point of time, she was having severe limitation of physical activity. So during labor, she was actually grade 4. Okay. And why do we talk about this? Because when you have this severe disease, we should not allow the patient to go for pregnancy. We should not allow them to go for pregnancy unless you optimize their disease. You restage her New York Heart Association classification. This stage has to be modified. We have to actually optimize her by medical or surgical treatment. So because she is now prone for, she's already gone into failure, so that means her mitral stenosis must have been critical. That is what we have to think retrospectively, correct? Okay, so now our patient has rheumatic heart disease, and she is actually, initially she may be medium risk, but when she presented to you, she was very high risk. And all these factors, infection, labor pains, augmentation with oxytocin, that is IV fluid and oxytocin, then again the surgery and anesthesia, and the oxytocics which must have been given after the delivery of the baby, all of them made her prone for cardiac failure. So what are the poor prognostic factors, Dr. Jasmine?
Any coincidental infections, ma'am? Then if the cardiac output is less and she's presenting with recurrent pulmonary edemas and any thrombus over the valves and presence of infective endocarditis and very critical stenosis, as an rheumatic heart disease, severe pulmonary hypertension. These are the things that can present with poor prognostic factors.
Yes. So we have to keep all these things in mind before we allow the lady to become pregnant and go ahead with all these stressful situations. So Dr. Poonam, what are the aggravating factors? We have actually discussed it here. But just to revise, what are the aggravating factors which we should keep it in mind?
Aggravating factors like she had infection which was missed. Then she had tachycardia associated with infection.
Yes.
And
fever,
she was given trial of and she was given trial of labor.
So pain, yes,
pain. And then she was given she was taken for LACS, and then she was
and then the IV fluids also. She was augmented also. So augmentation with oxytocin and IV fluids that added fuel to the fire. Okay.
Yeah.
So all these, but now just this was for this patient, but otherwise anemia, hypertension, of course, the rapid weight gain, multifetal pregnancy, pain, and the drugs like tocolytics, what we have been talking about, isoxaprine. So if these were given in the antenatal period, she is more prone for going into failure. So we do not, has Dr. Sujata joined? Not yet? Okay. So once again, we go to Dr. Manisha. Once again, we go to Dr. Manisha, and we just talk about what are the effect, why are we worried so much about heart disease, apart from this cardiac failure, what are the effects of heart disease on pregnancy and pregnancy on heart disease?
So with this, with pregnancy, the heart disease can be aggravated, like what we have already discussed, because she was having fever, she was having pain, she was having PROM, and which created her infection also. So that infection.
What can be the complications of pregnancy because of heart disease?
So
antepartum, what are the
because of heart disease, the pregnancy, that is for her, it's a high risk pregnancy, and that can affect her baby also. That she can land up in preterm labor and IUGR, just because there is low cardiac output, and because of that may affect the fetal outcome, and it would lead to IUGR and low birth weight babies or preterm labor also.
Okay.
And postpartum period also would be
yes, Dr. Jasmine, do you want to add the effect of heart disease on pregnancy? Yes, Dr. Jasmine, do you want to add something?
Madam, it's presenting with the cardiac failure that can affect the growth of the fetus and the accentuation of failure in pregnancy, which can recurrent she can go for recurrent pulmonary edemas, and present with infective endocarditis, and meanwhile she can go for sepsis, lactation failure, and other things.
Yeah, and so postpartum sepsis, postpartum depression. Yes, so all these factors are complications
also.
Yes. So what are the effects of heart disease on pregnancy?
Anemia is further aggravated.
No, we are talking about the heart disease on pregnancy. How does pregnancy affect the heart disease? That is what we have talked about, the worsening of the cardiac status, and of course the patient is more prone for cardiac failure, endocarditis and pulmonary edema, and she's more prone for pulmonary embolism and sometimes rupture of the aneurysm if she has. But there is no long-term basic effect on the basic defect. That means how the valve is spoiled because of pregnancy. That doesn't happen. But for the fetus, yes, there is 5% chance of the baby having congenital heart disease in addition to all these factors. Okay, so we go ahead with the next case now. So we have this lady who is 22-year-old primary gravida. She comes to you for the first time for checkup at 10 weeks. And when you examine her height is 152 centimeter, weight is 69, the BMI is 30. She doesn't have family history of diabetes. So I ask you once again, Dr. Manisha, does she need to be screened for diabetes? If so, yes, then when? What screening test is to be used?
Ma'am, she is having her BMI 30, so which is quite high, and she comes in the category of obese. So and at 10 weeks, we should definitely screen her for diabetes, and we would like to do.
Should we screen her only because she is obese? Only obese ladies we should screen, or how? So the message here is, Dr. Manisha, the message here is that previously we used to screen only the high risk women, that is obesity, age over 35 years, family history of diabetes, and the women with PCOS. So these were the risk factors which we used to screen. This was called as a risk screening, and that was because we have so many complications. We have the effect on the mother as well as the fetus. For the mother, you have increased incidence of preeclampsia, various vasculopathy, nephropathy, retinopathies, and she's more prone for going into preterm labor, or maybe the labor dysfunctions, complications, PPH, and operative interventions. And for the baby, you have macrosomia, and of course the birth trauma, and immediate post delivery also the baby goes into hypoglycemia, and so on and so forth. So risk to the mother and fetus also both increase. And so nowadays, PIGO, FOXY, NHM, and DIPSY, all of them recommend that every woman should be screened during every pregnancy. And that is what we label it as universal screening. The moment the patient comes to you, the lady comes to you as urine pregnancy test positive, she must be screened for GDM or hyperglycemia of pregnancy. That is what the message is. Now we come to what test should we do? Dr. Jasmine, you can take up this question. And then Dr. Poonam.
Yeah, ma'am, I would like to go for a glucose challenge test.
Yes. So how and when?
First, I would like to go for a random glucose challenge test. If the first trimester, I would like to go for a screening test like a random RBS. If it is quite okay, I want to leave her as such. And if it is the borderline,
anybody wants to differ with this? Anybody wants to differ with this, Dr. Poonam?
Ma'am, every patient has to be screened, and the screening includes the OGTT, which is recommended by
OGTT. This is called as single step 75 gram glucose.
25 gram of glucose, and then do the blood sugar levels after 2 hours.
Yes. And so now you describe me. Suppose a pregnant woman, comes to you, she's UPT positive. You want to go for OGTT. How much glucose you give? How do you dissolve? And how do you ask her to drink? And when do you take a blood sample? Okay.
Ma'am, first of all, she will be having her normal meals prior to coming to the clinic at night, and then early morning we will do her fasting sugar, and glucose has to be dissolved in 1 glass of water.
So the message, we don't want to give this message. The message here is very clear that we should not do multiple punctures, multiple samples for the lady. Whether she is fasting or no makes no difference. It's not necessary that she should be fasting. So irrespective of her status of fasting, irrespective of her timing of last meal, we have to go for what is called a single step, 75 gram glucose OGTT. That is, the blood sample is to be collected 2 hours exactly after she has consumed that glucose, 75 gram glucose. And how do you take this? You ask the lady to dissolve the 75 gram glucose in 200 or 300 ml of water. Ask her to drink it over 5 minutes. And then you note down the time. You withdraw her blood samples 2 hours later. Because it's a first trimester, sometimes she may vomit, but if she vomits within first half an hour, we have to abandon the test and call her at some other time. If she vomits after half an hour, we can continue with the testing. Now, what is the cutoff point? The cutoff point here is more than 140 mg/%. If it is the blood sugar level 2 hours after glucose, then this is labeled as, what is this labeled as? GDM. So if more than 140, it is labeled as GDM, that is gestational diabetes mellitus. But 120 to 140 is labeled as gestational glucose intolerance. Okay. So less than 120 is normal. 120 to 140 is GGI, that is gestational glucose intolerance, and more than 140 is labeled as gestational diabetes mellitus. If this sugar level, that is after 2 hours of glucose, then if it is more than 200 mg/%, then she is labeled as a case of overt diabetes, frank diabetes. Okay. So this is what coming to the diagnosis. Now you tell me, does the blood glucose level correlates with the perinatal mortality? We have heard about this, that it leads to fetal problems. It can lead to perinatal mortality. So does these blood sugar levels correlate with the perinatal mortality? Can anybody tell me? Dr. Manish,
ma'am.
Dr. Jasmine?
Yes, ma'am. If the blood sugar levels are high, then there can be chances of congenital malformations in the baby.
Yeah, but how you will correlate that?
Yeah,
how
then
much
we'll
blood
have-
sugar, how much is the perinatal mortality rate? We have to tell the patient.
If it is, if she's diagnosed, I mean, if the HbA1c is less than.
No, we're talking about the blood glucose
sugar
levels first.
If it is more than 200,
200, yeah.
Then the perinatal mortality is around 35%. And if it is between 150 to 200, then it's 16%. And if it is between 100 to 150, then the chances are 8%. And if it is around 100, then the chances are again
Just
less.
like normal, yes, 4%. So we have to keep a watch on these figures, because these figures bring out stark necessity of the blood sugar control. And that is why all the women with diabetes, they should receive the nutritional counseling. That means the guidance about their diet, which is to be made very practically. Individually, she has to be told what is to be eaten and what is not to be eaten, or what is to be avoided. And we have to consider her socio-cultural habits also. If she is a pure vegetarian, you have to guide her that how she has to utilize the vegetarian food only to control the diabetes, and do not insist on having a non-vegetarian food. So all these things we have to keep it in mind, and we have to see that the target levels are maintained between 69 to 90 before breakfast. Lunch and dinner, it should be 60 to 105, that is pre-lunch or pre-dinner, and post-meal, it should be maintained at 120. So anytime it goes above 120 post-meal, then patient needs to go for medication. So once you diagnose the patient as having GDM, you give her 2 weeks time. 2 weeks time. Why? Because you want to advise her on medical nutritional therapy. That means the diet modification, not to have any sweet, not to have sugar, not to have the simple carbs. So that is what you have to advise. Simultaneously, you have to give her a practical advice on the exercise. What kind of exercise she can go for, at least 30 minutes of optimum, that is moderate exercise she has to go for. And how do you this HbA1c levels? HbA1c levels do not indicate the blood glucose levels, but they are only useful for monitoring the sugar control over last 3 months. So if at the beginning of the pregnancy, once you diagnose her having as GDM, and if you do her HbA1c levels, if they are more than 10, you have to explain her. You have to write it from her that the HbA1c levels are more than 10. So her chance for getting congenital malformation is very, very high, that is 31%. And still whether she wants to go ahead or continue this pregnancy, that will be her decision. So informed written consent has to be taken. So this is how you correlate the HbA1c level with the congenital malformation. So we have done with this Indian guidelines and DIPSI. We have already discussed how to go ahead with the diagnosis. This is the algorithm. I have told you the patient comes to you for the first visit. You give her 75 grams of glucose, ask her to drink. You note down the timing, take her blood for testing. And once it is less than 140, you just keep her as negative, and you subsequently you test her for OGCT once again between 24 and 28 weeks. Anytime you get the lady as GDM positive, then you have to advise her medical nutrition therapy, and you give her 2 weeks time, and MNT with exercise. If her postprandial glucose levels after 2 weeks, if it comes as less than 120, that means she is well controlled on medical nutrition therapy. If her blood sugar levels 2 hours postprandial goes above 120, then that should be indicate that now she needs a medication. So how do you decide that how much calories she should consume, and what are the criteria to plan for her caloric intake? So Dr. Jasmine and Dr. Poonam.
Madam, we have to go by the body mass index. Supposing it is 18
1,
to
2, 3. What are
25.
all this criteria? How much weight gain she should have? What are the calories she is allowed? And how do you decide this? Yes.
So 10 to 12 kg of an average weight gain is expected, madam. And 350 calories above the adult requirement is recommended. And if the BMI is between 8 to 25, we can allow a gain of 11, it is allowed up to from 11 to 18 kgs.
Yes.
And if
So BMI
overweight, like
is,
our patients.
yeah, BMI is one thing you can decide. And what is the second parameter you consider for deciding
and the level
her?
of activity and
Yes.
the energy.
Yes.
She's a sedentary person. Our patient is a sedentary person. So their day will be 2020 kilocalories.
Yes. So Dr. Manisha?
And if we disordered work, the total expected.
Yes. So Dr. Manisha, we ask you here now, suppose you have this patient diagnosed at JDM, you are given a 2 weeks time, medical nutrition therapy, exercise, you do her postprandial blood glucose level, and if that is more than 120, that means it is not controlled on MNT. Then what do you do? Whether you start with medications and what medications?
If she is not, the blood glucose is not controlled with MNT, then we would like to start her with insulin. And we'll first do her fasting and postprandial insulin, and according to that, we will manage her dose of insulin. So
fasting and postprandial glucose levels.
Glucose level will do, and then accordingly we'll have to manage her. Adjust the dose of insulin, and or else metformin can be used. I'm confused. I don't know whether metformin can be used or not. Yes. Because if it is more than 20, between 120 to 140, I suggest metformin would do its work. But it's I would like to ask you, ma'am, whether
yes. In fact, I'm trying to listen to you because I want to know what is your practical experience. What are you using?
Practically, actually,
I'm asking all the panelists, Dr. Poonam, Dr. Jasmine.
Madam, I would like to go for insulin, ma'am, because
so insulin is the first line of therapy. There is no second opinion. The evidence says that insulin is the first line therapy. But considering the Indian scenario where we do not have, the hospitals, even the paramedics to counsel and to give injections. I'm sure you all must have experienced this, that at the remote places, they do not have somebody to prick them. They have to go long ways for taking the injections also. And how do they monitor their blood glucose levels? So you need a counselor, you need a healthcare provider, and then you need the facilities for doing the blood glucose testing. So if you want to avoid all these complications of hypoglycemia, these are the situations where you can go for metformin. So what the evidence is that metformin and insulin are equally safe and effective, but insulin is the first line of treatment. And this is what the justification, only where, there's absolutely no facilities, it is something is better than nothing. So you can manage these women. So metformin or insulin therapy, they are the accepted medication for pregnant women with GDM, not controlled on MNT, and insulin is the first drug of choice. Metformin can be considered after 20 weeks of gestation. So because it crosses the placental barrier and there is a fear of congenital malformation, that is one. And maybe metformin can lead to fetal growth restriction. That is also one more concern. And that is why we are little worried about metformin. But as we have already discussed, where situations are so that you just cannot go for insulin, in those cases, you may have to choose for metformin. Even today, there are many proponents of metformin. People are using metformin and doing good, getting good results with GTM with pregnancy. So with this, we finish up this case here, but because we have a similar case, we will take this diabetes ahead. So once again, I think I come to Dr. Manisha, or now we start the case from Dr. Poonam. So 36-year-old lady, previous one seizure, now 26 weeks pregnancy. She's diagnosed diabetic during 3rd month on, and she's already on insulin. Okay, she is a overt diabetes. Case of overt diabetes, she's already on insulin. Her HbA1c is 6.5. Her blood pressure is 150, 90 millimeter of mercury, and clinically, she has developed small for gestational age fetus. So how do you manage this case? Yes, Dr. Poonam. Poonam is already muted. You need to unmute.
Yeah, ma'am. She is a case of previous cesarean section with gestational diabetes with preeclampsia, and that's the reason why she is having clinically small for gestational age baby. And in this case, we go with the investigations. If we consider her from the first trimester, she has to be screened for dual marker. Then for in the 11 to 13 weeks of pregnancy. And then we go with the biophysical markers as well. And then in the second trimester, we go at 15 weeks, we go with the quadruple marker, and we go with the Doppler studies also. So all this give us the prediction of what preeclampsia she would be landing up. And then in the second trimester at 20 to 24 weeks, we go with the target scan, that is 4D color Doppler scan, to rule out congenital anomalies, as she being the gestational diabetic patient.
Correct.
Now,
one more thing you have missed out, which is there on the screen.
Screening for morbidly adherent placenta, as she is the previous CAR patient.
Yes, yes. That is what we can diagnose at the very the early pregnancy also. 11 to 13 weeks is the time where you can actually suspect the presence of morbidly adherent placenta. And at the same time, the uterine artery pulsatility index and the cervical length, all this can be, you look for in addition to the fetal soft markers. Okay. What else? Now, suppose this patient is on insulin, as you have said, she is on insulin. So if her blood sugar levels are between 120 to 160, she's on 4 units. And if it is between 160 to 200, she's on, she needs 6 units. More than 200, she needs 8 units. Okay. So now with this insulin, how do you monitor? How many times you test her blood sugar levels? How do you go ahead with management?
Initially, it was said that 7 pointers, but now we can go with 4 points as well. That is before breakfast.
7 points, all of us know. And what is your take on 4-point testing? What will be those 4 points?
4 points will be first before breakfast, second after breakfast, then after lunch and after dinner.
Okay. So 1 fasting and 3 post meal, you can say.
Post meal. Yeah.
Correct. So how do you interpret that? How do you decide now your insulin requirement?
The blood sugar level should not go beyond 120. And
what about the fasting? What about the fasting?
Fasting, it should be below 100.
It should be 95 and less.
Yeah.
It's a standard protocol here that it should be fasting blood sugar level should be less than 95. So you have to maintain fasting less than 95 and postprandial less than 120. Okay, at no point of time it should go below 105. That is what also you have to remember. Okay, so suppose your fasting is more than 95, then how do you increase the insulin? And when do you increase? Fasting is more than 95.
If fasting is more than 95, repeat fasting blood sugar and 2-hour postprandial blood
I'm
sugar.
asking you, if fasting is more than 95, then how do you increase the insulin? Which dose of insulin you want to increase? Fasting is more. So you have to increase the previous night's dose.
Yeah.
Yes, post meal. Yes,
yeah.
that you have to increase. The post dinner. Okay. Because at night that you have to increase, considering whether it is slightly increased elevated blood sugar level, or if it is significantly increased, then you may have to increase by 4. If it is just slightly elevated, you have to just increase by 2. Suppose your postprandial is going more than 120 for the lunch itself, then what do you do? Postprandial, that is post lunch, is going more than 120.
And we
it's
have
very simple. I'm telling you stepwise. Yes. If fasting is more, so this is you have to increase the previous night's insulin. Similarly, post lunch is more, so you have to increase the pre-breakfast, the breakfast insulin you have to increase. Okay. Yeah. So that is how you have to adjust the dosage, and you have to see that at all point of time your fasting should be less than 95 and 2-hour postprandial should be less than 120. That is what the ideal levels to be maintained. If your patient is maintained on these levels of blood sugar level with your MNT, exercise and insulin, then you can take her up to term. Now, what is this mean by? How long do you want to take her, and when do you want to deliver her?
Usually by
34 weeks.
38 weeks. 38 weeks.
Usually by 36 weeks.
Definitely not 34, because all of you know that GDM, the patient has poor lung maturity, in fact, delayed lung maturity. So even near term 38, 39 peti also get HMD. So you have to really prepare this baby with. That comes a turning point now. Should the betnesol or the steroids be given or no? If yes, how? What precautions you have to take? You can take up, Dr. Yeah, who else? Yes, Manisha?
In this case, ma'am, since she is having her blood pressure 150 by 160, means she is she's having PIH. So in that case, and if the chances, if we can consider her to deliver at 38 weeks, then I think there is no need.
No, we are not talking about hypertension, because she is having mild hypertension. Maybe you can. This is a point where you can start with a labetalol tablet and see that she is well controlled on that. What we have to consider is, because of diabetes, can we pull on her till at least maybe 37 weeks? Okay, 37 weeks. Because you have to see, you have to balance both the diabetes as well as hypertension. You have to balance both, not the preterm baby also, not the IUD also, right? So you have to be very vigilant. That's the reason I'm asking you, how long do you want to take this patient ahead? So at least 37 weeks, I would say optimum. Okay. So if everything is fine, I think just prepare this patient with steroids. Steroids, all of you know, betnesol, dexamethasone, whatever you are using, 24 milligram in 24 hours, not to go into the details, whether 12 milligram, 2 doses, or 6 milligram, 4 doses, whatever may be, you are giving us steroids. What is the problem with diabetes? Does it worsen?
Yes, it increases the blood sugar levels.
So what are we supposed to do here? Your patient is stable till now, but when you're giving the steroids, her glucose control is disturbed. You need to hospitalize her once again, and you have to actually observe her. If the blood sugar levels are disturbed too much, you have to increase the insulin dosage, maybe for 2 to 3 days or so, because they come back to again normal. So almost for 48 to 72 hours, the control gets disturbed. This is not only theoretical, this is practical observation as well. Okay. So you have given her steroids and everything is well maintained, your patient. So you have maternal monitoring and all the investigations weekly. For blood sugar levels, you are monitoring. Fetal well-being, you are monitoring on ultrasound as well. Now, when do you want to deliver her and how? Do you want to go for cesarean section or you going to induce her? How do you go ahead?
First, we have to.
Yes.
We have to admit her. Then we on the day at 37 weeks. And then we have to stop.
She said, doctor, everything is well controlled. Why do you want to admit her? Admit me.
She needs counseling that if carried on, then there are the chances of fetal demise if her sugar levels are not controlled as it's seen.
Is it? Is it? No. If everything is fine, that is a question. If the mother is stable, sugar levels are well controlled, she's all well maintained on this level of insulin, and her growth, well-being of the baby, see, you can see here, everything is good. That's the reason we want to plan her to take her till date, maybe 37 weeks plus. Okay. So if everything is fine, in spite of that, this is a chart showing you if things are good, mother and baby, everything is good, you may take her to 37, 38, even she continue up to 40, 41 weeks. This, are we not taking this patient for till term for spontaneous labor and delivery? Are we interfering every time? No. If things are okay, see JDM cases and diabetes mellitus, if they are well controlled and there are no fluctuations of blood sugar, then definitely we can at least take them to 37 weeks. That is what, even though G chart says 40, 41, practically we take it as 37 to 38 weeks. If she's going into spontaneous labor and if the baby weight is less than 3.8, we can deliver her vaginally. If a baby weight is more, 3.8 to 4 kg, then we have to induce her. And if her baby weight is more than 4 kg, then we can offer her elective cesarean section. These are the guidelines actually. So practically what we have to decide is, at least we have to see whether it is not 3.8 kg as absolute. We have to see whether the fetus and the maternal pelvis, everything is well. If she's going to deliver vaginally, naturally, you wait for that. If she's as it is, she's got contracted pelvis and this is or maybe feto-pelvic disproportion, you will not wait for that. Okay. So the guidelines say that this is the guidelines. If it is more than 4 kg, then only elective Caesar, and 3.8 to 4 kg, then you have to go for induction, because this is what is when everything is normal. Even practically, we do not intervene or go for intervention when the patient has diabetes. We do not routinely go for intervention. We can wait if the lady is stable and the fetus is well. So that is why we come to the next question. How do you monitor this labor? Suppose she goes into spontaneous labor, her fetus is well, her pelvis is good. So how do you monitor this patient in labor? Yes. What about the insulin dosage on that day? What about what she should eat? Whether she should go for have IV fluids or how? Is it something new I'm telling you?
On the day of admission,
we have to monitor her.
Yes, yes. Who is
on the
taking
day of,
this?
You can
on the day of
patient.
admission.
Yes. Who is taking up? Let me know. Dr. Jasmine?
Yeah, ma'am.
Yes. Yeah, please.
She needs a careful monitoring of both mother and baby, because during the course of labor and the stress of labor, she can go for ketoacidosis. So management of blood sugar during the process of labor must be
how frequently? That is my question.
And
every hourly monitoring the blood sugar levels every hourly, and it should be kept around 105, 110 mg%, right? Okay.
Yes.
Then
and if it is high, then infusion of insulin must be given.
Yes.
And she must be hydrated adequately with normal saline, because there is a IV fluids of choice. And we have to monitor the baby also for if it is either going for any distress or any other thing. Meanwhile, she has to be get a check on whether she's going for acidosis or not. So in spite of hydration also, they can go for ketoacidosis. So that must during the stress of labor, and that must be monitored. And if baby is going for any distress or CTG variations of the baby, we have to go for a cesarean section.
Yes, so that is a point of operative intervention, definitely. Okay, so if at all the patient, suppose you take up some patient for elective cesarean section, what will you do for insulin? Whether you give the insulin on the same day or you skip it?
Skip the morning dose of insulin.
The morning dose.
The patient is nil by mouth because you have taken her for, you have decided to go for elective caesar. You skip the dose of insulin that day. You monitor her, and anytime you find that she needs insulin, then you have to add it to the infusion. And how much insulin you have to add? It is here. Now, if the sugars are between 90 to 120, she doesn't need any insulin. Okay. If the sugars are between 120 to 140, then she needs 4 units to be added, and it's almost 16 drops per minute. That is what the infusion rate. If it is between 140 to 180, then 6 units, and more than 180 to 200, it is 8 units. That is what is the requirement. Immediate post-natal visit. Usually the GDM patient, next day her blood sugar level comes back to normal. But this is a diabetic woman. What do you expect in her? Manisha.
Ma'am, then in the postnatal visit, we'll have to educate her regarding her diet.
We were talking about immediate post-delivery.
Okay, immediate post-delivery. We will do her blood sugar level every 4 hourly now, because we know that after delivery her sugar levels will come down, but still we'll have to monitor this her still till she is with us for 3 to 4 days. And if the blood sugar levels are coming down to normal, then we can decrease her dose of insulin successively. And if it is
so there is no need for 4 hourly, but it is like after every meal you can decide. And then definitely her insulin requirement comes down during the postnatal period. And then you have to adjust her again. So how much insulin she needs at discharge, you have to finalize. So first 2 days, you have to actually monitor her blood sugar levels. At discharge, you have to monitor the blood sugar levels, and weekly, and then at 6 weeks, you have to really monitor her blood sugar levels. So this was our patient who was actually diabetic. But even when we have the GDM patient, down the line 5 to 10 years, she is going to be the overt diabetes. And that's the reason you have to tell these ladies that whatever lifestyle you have acquired now, that not to eat sweets and go for physical exercise, the diet modification, she has to follow this. Otherwise, she will be overt diabetes maybe in another 10 to 20 years. What contraception is preferred for these diabetic ladies? Diabetes, so not a hormonal imbalance, whatever hormonal changes, we don't want to have that. So we have to skip hormones especially. And copper T. Yes, copper T is what is called as MSC1, that is most preferred contraceptive that we have to advise her for, copper T. Okay, so this just to conclude that insulin is the preferred treatment for diabetes. It is the first line therapy, and metformin should not be used as first line treatment, as it crosses the placental barrier and can go to fetus, develop fetal congenital malformation. Of course, with the patient of PCOS, when she conceives on metformin, she is already having, you should not stop it till at least 12 to 14 weeks. And once she is crossing that level, maybe you can again go for investigation and decide whether she needs insulin. So with this, I conclude my panel discussion. And yes, only 3 of you, but I really enjoyed moderating the discussion, and I'm very happy that you all have given wonderful inputs from your side. I thank the organizers, and I take this opportunity to seek your blessings and wholehearted support for my candidature as Vice President FOGSI from West Zone. And from West Zone, we have 2 posts. So in addition to me, you have one more opportunity to decide the candidate. From my side, I just request you all to support my candidature. The elections are in August, 1st to 10th August, and I just request all of you to vote for me then. Thank you so much. Over to you, Kalpana.
Yeah, it was a wonderful panel discussion, interesting cases. We really enjoyed it, and the panelists were the information given by them was really, really great, and all our delegates would have enjoyed by this panel discussion. Thank you so much, ma'am. Thank you, panelists, for your information, and it was really interesting. And
Thank you, ma'am.
One more humble from my side. I am contesting for Infertility Committee Chairperson, and I've been working hard for various committees in 10 years and 6 years in Infertility Committee, and 2.5 years as a national coordinator, working hard with under the guidance of So I humbly as a chairperson of Infertility Committee in the will be the voting. Radhika?
Thank you, ma'am. It was very elaborate and indeed very enlightening to all of us. Touched on all the medical disorders, most of them heart disease also. So that is very good. Thank you so much, Sneha ma'am. And especially diabetes is most common. And all of us have little doubts there, here and there. You cleared all of them. Thank you so much. And thank you, Kalpana ma'am, for the session on endometriosis. And thank you all the panelists and the chief guests. And
once again, my sincere thanks to both the federations, AMOGS, with its President Pardesi sir and Dalvi ma'am, and also our own federation, Revati ma'am and Sampath ma'am, for guiding us to make this program a successful one. Sneha ma'am, thank you for your guidance too.
Thank you.
Thank you so much. Thank you, dear all. Thank you, Manisha, Poonam, and just me, my wonderful panelists.
And we
Thank
wish
you, Dr.
all
Gauri.
the best to you, ma'am.
Thank you. Thank you so much, dear. I need your wholehearted support.
Yeah, ma'am. We are definitely
Best of luck, ma'am.
Yes, thank you so much. Because I'm working for Foxy since last 20 years, if I tell you, and I have been working for each and every committee till date. I can name the Rural Obstetrics Committee, MTP and Family Welfare Committee, Young Talent Promotion Committee, and so many other committees I have actively worked for, and Breast Committee and Public Awareness Committee. I was the national coordinator then. So I think almost all committees of Foxy I have worked, and finally I have served Foxy as Breast Committee Chairperson. And I would just say that we deserve, and we are working very hard for that. So with all your blessings and support, we want to go ahead. Thank you so much.
Observe us, and if you feel that we are working hard, please support us. Poonam ma'am, Nisha ma'am, thank you so much.
All the best to you, ma'am, also.
Best of luck.
Thank you. All the best, Kalpana. Sure. Bye-bye. Thanks, Dr. Gauri.
For this event, it was really a wonderful coordination, and I also thank our Shield Pharma for giving.
Yes. Thanks, Kalpana. Thanks, Chitrakala.
Thank you so much, ma'am.
Chitrakala and Shahiti for your technical support. You are always with us. Thank you, team.
Thank you.
Thank you so much.
Thank you.
Bye-bye.
Thank you. Good night.